So yes, I am a neurophysio, and so I'm really privileged to be sharing with all of you. And I certainly can't say that I'm an expert in ME because my journey is ever growing, and my learning on ME, even through Nicole's very helpful um, presentation just then, continues to grow as well. So I'm really privileged to be invited by Rachel to present. And I hope that my personal experience as a neurophysio working with a few severe ME clients could be of benefits to some people. And most certainly, it's been truly beneficial to me. So the scope of my presentation will be principally about my experience working as a neurophysio, what I've recognized as the treatment priorities and goals, what outcome measures or lack thereof from physiotherapy that we can use. Summary of my learning so far and my vision for how that ME and people with severe ME can really benefit from our service into the future as well. So I think Nicole has summarized it really nicely, and that certainly is my personal experience as well. That's working in the space of severe ME. I didn't know that there was such thing as severe ME. There was a real lack of training. And in fact, I was just doing some lit search and consistent with what Nicole was sharing as well, Febiatel, he and their group, actually, they looked at health professionals and how much do they understand about ME. And they found that a third to half of all GPs don't actually accept ME as a genuine clinical diagnosis or clinical entity. And that is in 2020. And we're not, we haven't really moved too far from that really currently. And really, that's where I started when I was going through physiotherapy school between 1993 and 96. I've never heard of ME. I've never heard of chronic fatigue syndrome for that matter either. And I knew nothing about it. And even now, I work as a clinician, a teaching clinician at a prominent university. And I'm not aware that the students are being taught about ME either. So there's certainly a lot to be changed or improved in our education system. So personally, the first time that I did come across ME was working as a neurophysio community base in the UK, where I was asked to come up with a personal statement because there were a few clients coming through the surface. And actually, I never ended up seeing them, but I did have to do some research. And it became a very confusing research because I found so many things that I couldn't really grapple with. And the two key contrasting schools of thoughts that I found at the time was the psychosocial model versus the neurological model. And obviously then at that time, and that was like 20 years ago, the PACE trial was really big. And, the graded exercise therapy as well as the cognitive behavioral therapy, they were really big, and they were just being the push at the time, and it was being put into the NICE guideline of the time as well. And obviously we're all aware that in the 2021 NICE guideline that's been taken out. So as a neurophysio, though, clinically, I also found that unlike stroke, Parkinson's, and other very, commonly sort of seen neurological conditions, ME is much harder to grapple with for neurophysio. There wasn't anything, even now, we're still building up our knowledge, but in terms of MRI scans, CT scans, diagnostics, there's not a lot of clear for neurophysio. Those are the things that we look for, and there's no clear structural lesions that we can find in a brain scan that's consistently reported. And so at the time, 20 years ago, then it was a very natural thing for me to gravitate towards that psychosocial model, unfortunately. So now fast forwarding 20 years later, with the advent of more functional MRIs being done and more research and more scans that are done of more people, and together with my personal experience of having more exposure to real people with ME, I am now much more appreciative of ME as a neurological condition. So yes, I can see, and I now know that it is a neurological condition, but it has been a long journey, and I'm sure that there's not many of us who actually really do appreciate it very much. As I mentioned, there's a real lack of education even now. So I think that in my presentation today, then what really helped me and what I think it's information that I like to share with other neurophysios and other physios as a whole are the new knowledge that we now have. And Nicole already sort of shared a lot about the new diagnosis, the international consensus as well. But what is particularly interesting for a physio that I feel that is, useful for all neurophysios to know as well, is that there's definitely central nervous system pathophysiology going on, and that we've got good theories now to help us explain what's going on, even though we don't know what started it in the first place, that we can see that there are pathophysiological processes going on. And specifically, some of the named processes now in literature are things like neuroinflammation and central sensitization because of possible structural changes and definite functional changes in our central nervous system. So, and the other thing that's important to note is that now we know that the PACE trial findings are disputed, and that the graded exercise therapy is now excluded from the NICE guideline for ME management. And obviously, yes, we have learned that the Australian standard still has that for CFS, but certainly for ME, it's excluded from the NICE guideline, which is important for us to know. So now then, yes, we've gone through that diagnosis, which I won't repeat, but I think particularly also from a neurophysio's perspective, the few things that I find particularly interesting are the specific name networks that are involved in your ME sort of brain. And I'd love to share with you because I'm passionate about knowing what's going on inside the brain and what the networks that are involved. So the exemplified or the listed networks that are affected are, one of them is actually your default mode network. And that particular network actually involves a few structures. And these structures are your anterior medial prefrontal cortex, your posterior cingulate cortex, and your angular gyrus as well. And actually, the interesting thing and fascinating thing about this network is that this is a network that performs your self-directed thoughts and introspection when you're reflecting on things in your subconscious, what's going on outside of when you're performing a task. Your default mode network is at work, helping you to process things that have gone on throughout the day. And it's really interesting that repeatedly the default mode network is demonstrated to be dysfunctional in your ME population. Another network that is affected is your salient network, which actually is the network involving the structures of the anterior cingulate cortices in the brain. And that particular network, it performs sensory processing and response, selecting stimuli that deserve our attention. So that really helps me to understand why that processing stimuli like noise and touch and temperature and all the kind of variety of sensory reduction in tolerance that the severe ME population or your ME population as well, that they experience. So this salient network is really a very important network in helping us to process things, make sense of things, and formulate a homeostasis in the way that we actually, understand those kind of sensory information. Now, the last consistently reported network dysfunction is the difficulty in the switching between the default mode network, that subconscious reflection introspection network that we just spoke about, and the central executive network, which is the network responsible for attention, your working memory, as well. And so the structures, like I said, I'm interested in structures in the brain. So the structures that are involved are your lateral prefrontal cortex, your posterior parietal cortex, and your dorsomedial prefrontal cortex. And so those areas of the brain are involved in that kind of attention working memory, and it's the switching between that particular network and the network of your subconscious, your reflective processing. Those two networks, when they're not switching well, is what we find in your ME population. So that's amazingly interesting for me as a neurophysio, and that's I think that would really fascinate other neurophysios to get involved in the area of ME if they realize that these networks are being affected. So Nicole's already gone through about the diagnosis of ME, and that's certainly the other thing that neurophysios, a lot of the neurophysios are totally not aware of, this issue of PENI and that cognitive impairments and this energy transportation production issue involved, which certainly have huge implication on the delivery of physiotherapy, because physiotherapy, as a lot of us know, has a lot to do with physical movement, exercises. So it's really difficult, and it's certainly something that we really need to adjust, adapt, and be creative about as physios. So what are some of the neurophysio goals? In the NICE guideline, it listed quite a few things, and I want to share some of that and give you a summary of that. But also, following that, I'd like to share with you some of my sort of personal experience of applying these things as well. So the NICE guideline for ME does talk about the importance of knowing that physiotherapy is not aiming for a curative sort of process. Even in terms of rehabilitation, we may not necessarily be looking at improvement or restoration. And so ideally, if we can see a maintenance of physical function and a slowing down of the decline, that would be really what's realistic to aim for. Now, whilst we are doing that, how do we do so whilst minimizing us depleting someone's energy level and being totally incorporated in that energy budget and banking strategy that the person has in place? And how do we contribute to that budgeting and banking? And that's something that's really quite I think it's very much the bread and butter of the OTs, and where you're really, really good at. And as physios, traditionally we're all about doing more and doing better and increasing the resistance and so on and so forth. But having us to be very respectful of that energy conservation kind of process is quite something that we all have to get our minds around. And certainly it's not something that I'd expect a new grad to be able to do very well when they're trying to work through some of the other things that they're learning in physio. Now, the other thing is then, and I think this third point is particularly helpful because, how do I, as a physio, then monitor this energy depletion issue and not actually make it worse for your ME clients? And just learning this, in fact, I learned this from the webinar from last week, the monitoring of your heart rate, and reading through some of the guidelines that have been shared during that seminar of knowing what is the resting heart rate that is the starting point for your client, and then how do we then work within that limitation? And yeah, that was really, really helpful, and certainly in that particular guideline I read about doing it over a 7-day period in supine, lying on your back, knowing what the resting, normal resting heart rate for that person is, and not working more than 15 beats, which actually really doesn't take much at all. A few passive movement of a joint can actually, throw this person out of that range already. So, we have to be really quite careful, as physios in monitoring that. Now, the other thing is actually about risk assessment. What is it that we do, or even beyond us, what support people, carers, they do that may be worsening the symptoms of our ME client? this risk assessment is something that we certainly need to get much more involved with our OTs to work jointly on. The Visible app I downloaded actually last week because of learning it from the webinar from last week, and it's certainly very helpful as a tool to help us to help the person with ME also monitor whether they are blowing their budget or they're staying within budget. So now I think Nicole already shared about alternative modes of delivery of therapies. And I haven't done too much of the online sort of therapy sort of delivery to my ME clients. In terms of assessment, I have done them in the kind of telehealth setting. But therapy-wise, I've been fortunate to be able to deliver some things face-to-face, which to me as a physio, it's really helpful to see that person. And because a lot of my observation is everything. It's the person's environment, it's the person's facial expression, it's the person's muscle tone, it's all of those things. So I've done lots of things that are not what a usual physio will do in my experience with treating somebody with ME. But before going into that, outcome measure is particularly challenging for a physio. I think because, for your moderate ME, maybe we can do, or mild and moderate, we may be able to do a 6-minute walk test or, sit to stand, a timed up and go, and those physical testings that we use a lot of. But actually, once you get to that severe ME sort of stage, then you really can't, there's really no standardized clinical outcome measures that we can use. But maybe that now that we know about the resting heart rate, we might be able to track the trends, and maybe that can become something that's more standardized, that we can observe more. Sleep quality and penny or pen sort of frequency of a person going into pen, maybe ways in which that we can detect more. But again, like I said, that's very much as a physio, I have to be much more creative in knowing what kind of standardized outcome measures that I can use. So what have I done really in terms of my treatment with my ME clients? I've been involved in things that are just so different to what I traditionally would do. Lots of, gentle passive movements, or well, not lots of, just a few of. And then soft tissue work, really gentle soft tissue work, joint mobilization work. So a lot of that manual therapy for your severe ME, because of the inability for them to mobilize, their body gets stiff, painful. And I then have to really lean on those manual therapy skills, but constantly then still monitoring, because as we know also in intensive care, what do we do to get somebody who's not responding to exercise? We do passive movements. So actually we do know that even passive movement can actually heighten someone's heart rate. And with your ME clients who are in a state of paralysis, you've got to be really careful that we are actually monitoring what impact that it is having on our our clients' cardiovascular system. So yes, and actually outside of the box, I've been very involved with one specific client, just even being very specific in detailing every sort of writing up the care plan and detailing everything that the person with ME wants their carer to do, and very much involved in educating carers about the triggers of penny and the pathophysiology behind the condition, and so on and so forth. And consistent with, I think, what Nicole has already shared, it's frustrating. It's been a frustrating journey, and certainly I'm sure Rachel doesn't mind me mentioning that she's really had a terrible journey in helping people to understand her condition, not necessarily seeking for empathy, but for mutual understanding and respect, and that even though we've spent a lot of time explaining, people become complacent, they become unreliable. And unfortunately, that is just a recurrent sort of experience, which I really feel for. And so at this point in time, in my head, I'm also thinking, unlike the kind of client therapist or client support relationship that we are familiar with, what is really the best relationship, relationship balance to actually, I guess, share? Is it an employer staff? It's certainly not a patient clinician sort of relationship, because that really doesn't work and hasn't worked historically. And so in my head, I'm still sort of working that out. And this is a constant evolution. So in summary, my learning, yep, severe ME is poorly understood. We definitely need to share the word. And certainly for me, this presentation, I'm going to share with my team. And where opportunities arise, I'd like to have that opportunity to share with other physio students that I come in touch with as well. And that's I think that that client-led support model and what relationship that should be is still something that I feel like we're working on, so that our ME population can really get a fair deal in all of this. And that constant education and being there, knowing that you're severe ME individuals, they are fighting a lifelong lonely battle, and just being there for them, and being there not necessarily not as a not empathizing with them necessarily alone, but being there as a comrade, that camaraderie of support, and that learning from one another is some of my learnings. Okay, so I've shared a little bit about my vision already, and these are my references.